Hello and welcome to all of you on behalf of the World Organization of Family Doctors, WONCA. This is the fourth webinar in our series on human factors and primary care. My name is Maud Nauta, lead of the Human Factors Core Group, the organizers of this series. Your main host for today will be Dr. Roanne Osborne. She will introduce today's excellent speaker, John Toussaint, for his presentation, Saving Lives and Improving Care with Scant Resources, but with Imaginative Leadership. Before we make a start with John's presentation, just a brief recap for those of you newly joining this series, what human factor science is about and what the Human Factors Core Group does. Human factor science is sometimes also known as the science of work. It's a fundamental pillar of the WHO Global Patient Safety Action Plan 2021-2030, and the Human Factors Core Group was established around 2 years ago. Human factors is a scientific discipline concerned with an official definition, the understanding of interactions among humans and other elements of a system, the health system. The science is about designing systems in such a way that human well-being and overall system performance are optimal. So today's webinar covers some important principles for senior leadership, some of the prerequisites enabling human factors alignment within the organization, such as leadership behavior and how to create continuity of information within the organization. For family medicine, our vision is that by applying human factor science principles in strategic and day-to-day activities at individual and organizational levels, our primary care patients will have the highest attainable health and well-being, with care that is both patient-centered and free from avoidable harm. As WONCA is a global organization, our Human Factors Core Group's mission is to lead within the organization on human factors integration in family medicine worldwide by supporting family medicine teams to develop their own human factor language, applications, education and research, and adapt it to their local circumstances, to your circumstances. Some practical points. If you need to reach us afterwards, you can reach us via the email in the chat. We will put that in there. The chat is active for all of you. We have a topic covering low resource settings, so please start. Our question in the chat to you is, which regions and cities are you from? And which are you working in? What is your background and what made you join this webinar series? Please use the chat for this. The chat is also for you to put questions to our speaker or raise general discussion points or ideas. We will assemble your questions from the chat for in the Q&A session at the end. Dr. Roanne Osborne will now introduce our speaker. Roanne, over to you.
Thank you so much, Dr. Maldonado. So I have the pleasure of introducing our speaker today, Dr. John Toussaint. He is an internal medicine physician and one of the most foremost figures in the adoption of organizational excellence principles in healthcare. He founded Catalysis, a nonprofit education institute, in 2008. Catalysis has launched peer-to-peer learning networks, developed in-depth workshops, and created many products, including books, DVDs, and webinars. Catalysis sponsors the Lean Healthcare Transformation Summit each year, both in the US and in Europe. Dr. Toussaint has published articles in major medical journals such as Health Affairs and JAMA, and in major business journals such as the Harvard Business Review. He has written 3 award-winning books chronicling the journey of many organizations to enterprise excellence. He continues to be a student of building excellence into healthcare operations. He has learned from over 220 organizations in 19 countries, transferring this knowledge into articles and books and to executive teams around the world. Dr. Toussaint, welcome, and we look forward to your presentation today.
Thank you, Roanne, and welcome to you all. I'm very happy to be with you. I actually practiced primary care medicine for 20 years, so I feel your pain, and the things that I'm going to talk about today really are sort of transcend, I would say, all of medicine, whether you're in the hospital, whether you're in a clinic, whether you're in a home care unit. The basic behaviors that we're going to discuss today really transcend any of those particular places to really get to what I call organizational or enterprise excellence, which is what we're all trying to do for our patients, ourselves, and our staff. So I do have a presentation I'm going to pull up here. Interesting. I am unable to, there we go. So Catalysis was founded in 2008 by me. I'm a former CEO of a healthcare organization in Wisconsin called Theta Care. This is quite a few years ago that we established this work, and the work really is about helping organizational leaders understand what it takes to be great at everything they do. So our goal is to build a global learning system based on new knowledge generated with these linkages of healthcare leaders across the world. And so we actually have been studying in 20 different countries. What we found is that it doesn't matter what country, what culture, these behaviors sort of transcend all different types of cultures. So my goal here is to understand the basic principles and the framework for performance excellence. Understand the specific behaviors. So if we think about human factors, behaviors are part of that. So what are the behaviors that lead to excellence? And then understand how the systems that we create and the standard work that we build actually reduces human error in healthcare. And then the questions that need to be answered to build a culture of excellence. So I'm a big proponent of asking good questions, which then stimulate thinking. So hopefully we'll have some questions for you that can stimulate your thinking about your work. So this paper from the BMJ on quality and safety, if you scan down to the results, the primary goal of human factor science is to promote efficiency, safety, and effectiveness by improving the design of technologies, processes, and work systems. That's exactly what I'm going to talk about is the, how do you become more effective and efficient and more safe in the world that you're practicing in. So one question is, are human factors the reason for error in healthcare, or is it something else? And I'm going to argue that it's something else, and that if we build the something else, that we dramatically reduce errors that would otherwise happen if we don't have specific things to attenuate these errors. So what is the cause of human error? Contrary to popular belief, and I've worked on this now for over 30 years, process problems with workflows, problems with systems cause most of the errors. And in fact, you could say maybe it's 99% of the errors. In my experience, both as CEO and as practitioner and as coach, I would say almost close to 100% of the problems and the errors that I have studied are related to the processes of care that we use, not the people. And if the people have the right systems in place, they actually are very effective. So let's talk about some of those things. This guy, his name is Shigeo Shingo. He was an industrial engineer, worked a lot at places like Autoliv and in other companies out on the western part of the United States. And so he wrote quite a few books, many of which are difficult to decipher, quite frankly. But bottom line, there are 4 reasons to improve things: to make it easier, to make it better, to make it faster, and to make it cheaper. These are the 4 goals in order of priority. So look at that first goal, make it easier, right? We all know the burden that we face in trying to practice primary care medicine. We need to make that a lot easier And there's ways to do that if we think about the work differently. But that's the goal of trying to figure out how to make things better is to figure out what those systems are. So this is basically a philosophy that starts with a set of principles. So what are the principles, which I call the bedrock of your organization, your clinic, wherever you work? What are the principles that that your organization stands on? Because it's those principles that then allow us to talk about and build and agree on what are the specific behaviors that we're going to hold each other responsible for. And once we understand and agree on that, then we can start to build systems that actually reinforce those behaviors and reduce errors. And then obviously we have great improvement tools. Many of them, many of us have worked with those tools forever, and they're terrific. The problem is if you just use the tools, you don't sustain any improvement. So without this entire system of principles, behaviors, systems, tools, you really can't sustain any improvements that you make. So this is kind of a philosophical viewpoint of organizational performance that we have now taught and have seen become incredibly successful in many different organizations around the world. So what is the basis of this philosophy? What is the basis of everything that we talk about? And these are the principles. Again, if we go back to Shigeo Shingo, industrial engineer, he identified these core principles as the way to build excellence into everything that we do. And they really fall into three different categories. So there's the alignment category, and it always starts with let's create value for the patient or the customer. Let's understand what our purpose is. If we define specifically what our purpose is, we need to think across all of the parts of the organization, all the parts of the clinic, all the parts of the department, whatever, rather than just in our little silo. So that's thinking systemically. We need to build continuous improvement rigor into the work that we do. So these are the principles that do that: assure quality at the source, improve the flow of the work, always seek perfection, not be perfectionistic, but seek perfection. So meaning whatever we have today, we can get better tomorrow. Embrace scientific thinking, and that's simply just a SOAP note applied to your work. So subjective, objective assessment plan. Deming would say plan, do, study, act. It's the same thing as subjective, objective assessment and plan, only now we're applying it to our regular daily activities to improve them. And then finally, there's these cultural underpinnings of this work, right? So behaviors culture are about behaviors. And in this case, these principles are respect every individual and lead with humility. And so if leaders are able to incorporate these principles into their actions and work systems, this will be the bedrock for how you improve care over time. And we did it at Theta Care. There's many organizations within the US and the UK and Europe and South Africa that have done it. So this isn't theoretical. It actually has been proven by a number of different organizations. And here's one, or at least here's where one exists. This is one of the worst slums I've ever visited in South Africa, in the southwestern part of Johannesburg, which is the mining area of Johannesburg, gold mining area. And what happens is a lot of people from Africa come to South Africa to find jobs. The problem is there aren't enough jobs for all of these immigrants. So they end up living in conditions like this. And the problem is that when you have patients coming from this type of an environment, there's all kinds of different barriers and issues related to that. But as you'll learn in a few minutes, there was a CEO at the Lertong Hospital, which is kind of in the middle of the slum. And he decided to apply those principles I just showed you, build a culture of continuous improvement, and pursue excellence within the health system that he ran. Within a few months, they'd actually reduced their neonatal death rates dramatically. So just within 6 months, applying these principles, getting teams involved in continuous improvement, using PDSA cycles, they were able to dramatically improve the care of these very, very poor people. And this woman was one of the outpatient medicine managers. I'm just going to play you a quick little video of her explaining the processes that they were using in that clinic to improve care.
With us, we have got problems every day. So when we handle it, we're trying to solve problems ourselves, because the purpose of Lean is to develop our people to be problem solvers and improve performance. So when we also do it, if somebody identifies a problem, they come and pick up a paper from the improvement opportunity, where you say they write their name, what is the problem, why is it happening, and the potential solution. Then we meet at the board. We are supposed to meet 15 minutes in a day, but given the nature of our business, we assess, is it feasible for us to meet? So there are times where we do not manage to meet. Like today, we couldn't meet because we had to prioritize the patient. Then after that, to decide how much impact is it going to have on service delivery. Is it going to be high impact? Is it going to be the low impact? Or is it just kibosh, like a waste of time? So with this is saying that before we even start, we're going to assess to say, from the work in progress, how far feedback do we still need? How are we doing? Then that we prioritize on the ones that are written to say, today we are picking up this problem. And if the problem, some of the problem, let me give an example with the Just Do It, where to say that the files, they are not being found for clinical audit, to say why is it happening, the absence of plans, due to date of birth, and to say the potential solution, we just need to update the files as the patient comes. If already, let's say maybe the patient came and we allocated a birth date, then as soon as the patient has been registered, then the clerk, the file needs to be updated. And that didn't need us to really plan. It's something that the clerk could just do it, so that at the end, when we need the file, we could access the file.
So the beauty of that video is that manager is not solving the problems. She is asking the staff to solve the problems. And all those little sheets you saw up there were staff ideas about how to solve the problems. So the actual premier of the Gauteng province came to this hospital. And this is what he tweeted out at one point. I'm impressed with the outcomes of our unannounced visit. Feedback from patients is positive. The management system is working well, and the proper management and responsibilities of staff are clear. So, you don't get that. That's the premier is like the governor of the state. So you don't get that kind of feedback just willy-nilly. That was pretty impressive feedback from a top official in South Africa. So here's the journey. Here are my questions. I told you I was going to ask you questions. And so these are the questions that I, when I come on a site, that I'm very interested in learning about. And a lot of our books and papers have been written on this. So what's the underlying philosophy? Do you have one? What's it based on? What are the behaviors required to deliver results? That's the organizational behaviors. What are the personal behaviors that enable the development of improvement culture? What are the systems necessary, to support that culture? And how's the organizational management system being deployed? Is it being deployed? How are you going to choose the critical few initiatives? Another big problem that most healthcare folks have. So these are questions. You might want to step back after this webinar and try to answer some of those questions for yourself. And if you can't, then that, I think, maybe is a place to start in terms of understanding how you actually build this work into your daily activities. So let's talk about purpose. Have we defined our purpose, right? So at that Laratong Hospital, they had a very clear purpose: decreasing NICU infection rates, reducing postpartum hemorrhage, and reducing post-surgical infection. So they saved 75 babies a year from baseline. They reduced maternal mortality rates from 25 deaths a year to 0 over about a 9-month period. And they reduced surgical infection rates by 95%. How do they do that? It's like, is that magic? Actually, the magic was exactly what you saw in that last video. The staff were coming up with ideas to solve problems, and they solved problems to the tune of hundreds in a month. And once you start to unleash the teams that work with you and for you to solve problems, you can get dramatic improvements. So what are the behaviors at the organizational level? And I don't understand what your organizational structures are. But if we think about organizational structures and from the standpoint of there's a governance system, there's a leadership system, there's a manager system, there's a frontline system. Each one of those levels has different behaviors and actions that they must take. So let's look at it at the leadership level, at your level. So your role is to establish direction, vision, and strategies. The manager's role is to monitor the performance and ensure that the frontline workers have what they need to do the work. And then the frontline workers are saying, okay, what am I going to improve that's going to lead to excellence in our organization? So that is the align principles. The enable principles, again, if we start at the leadership level, energize people, develop and overcome barriers, right? It's not to tell people what to do. It's not to solve problems. Actually, at the manager level, this becomes the manager's job is to coach the people that do the work to solve problems. Most managers think their job is to solve the problems themselves. That's the problem. So what we want is to have a system in which the managers are actually teaching the people that do the work to solve problems. And then the people that do the actual work are sharing with each other and improving things together. And then if we look at the improve principles and we look at that leadership column again, what we want is to get breakthrough thinking. So how do I support breakthrough thinking as a leader? The manager challenges the process and monitors whether the things are improving, and the frontline workers are solving all the problems. And I can guarantee you, if you can put a system like that together, a lot of the problems that stack up on your desk are going to go away, and you're going to build a culture of improvement throughout the organization. So that's organization-wide behaviors. What about us as individuals? What do we need to do in order to unleash the creativity of the people that work for us and around us to improve care? So this is a rating system of a self-reflection chart that we've created. And I've used this self-reflection chart now in many different countries with many different leaders. And it's the one thing that leaders tell me actually made the biggest difference in their ability to change themselves. And again, this is what we're talking about. We're talking about changing our own behavior, and that is really, really hard to do. So how about a simple tool to help you with this? So there are 5 behavioral dimensions here that have been studied ad nauseum in just about any realm of leadership. So this isn't something that, I made up. It's something that we've learned over the years is from many different people like Jim Collins and Peter Drucker and others. But what we found is this tool is actually really, really helpful. So let me walk you through it. So willingness means willingness to change. Are you willing to change? It starts with that. And if I were to come and visit you and find out if you're willing to change, I would see in your diary or on your calendar a time during the week that you actually do self-reflection. And what I would be looking for example, not necessarily what you have to do, is what did I do this week that unleashed the creativity of my team? And what did I do this week that shut my team down? Those two simple questions. Self-reflection, 15 minutes a week. And I'll guarantee you it will have a big impact on the way you think about your work. The second one is humility. And so if I came to visit you, what would I be looking for as I went out to the workplace and watched you do your work? So what I would be looking for is that you go and see and listen and learn. So this is, if you're a clinician, you're seeing patients every day. But if you're a leader and if you have people that report to you, you need to go see what they're doing, because the reality is that you don't know until you go. And I was an internist, but I was also a CEO, and I can guarantee you that the vision I had as CEO, looking at the work, was completely different than the vision, the vantage point I had as a practitioner. Because as a leader, what you're going out to do is try to understand where the problems are that our people are facing. And so I would be looking for you to go see, listen, and learn about that if I were to come and visit you. The third dimension is curiosity. And in this case, I would be looking for, do you ask questions that start with what and how, not with who and why? Not with, did you think about this? So the idea here is that you're trying to unleash people's thinking. If you go tell them what to do, you think that's going to unleash their thinking. And so learning how to ask good questions to stimulate thinking is really important. And it's an important aspect of building excellence in everything you do. Effective listening. One of my great mentors told me years ago, listening is not waiting to talk. Okay, listening is about empathizing with the person you're with to understand what they're trying to tell you. So if you go out, if I went out to see you in the work you do, would I see you really empathetically listening to the people that are trying to explain things that aren't working? Or were you just waiting to talk? And then finally, A3 thinking, and those of you that don't know what an A3 is, it's simply a PDSA, plan, do, study, act. And what we need to understand, first of all, is what's the current state? What are our goals? Why can't we achieve our goals the way it is today? And then what are we going to do about it? Pretty simple, but I always tell people that when I became the leader at ThedaCare, this was the thing that changed my behavior the most, because I quit trying to jump to solutions. As a clinician, that's what we do. We jump to solutions. We have the answers, blah, 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 when we really don't understand the background and the current state of the existing workflows, existing work processes. So we need to step back and understand that before we make any determination of what we should be doing. So the fourth dimension here is perseverance. So it takes perseverance to change your behavior. Believe me, guilty as charged. It's hard to change behavior. So if you don't get good feedback about your behavior, it's going to be even more difficult. So can you identify a partner, a person, a buddy that can actually observe you in work, observe you interacting with teams, and give you feedback about how your behavior impacted the team? And I think it's so critical to identify someone like that so that you can get actually trusted, honest feedback about how you're actually doing from an action and behavior standpoint. Another way to do it is have a coach. So I've coached a lot of people around the world, and I've had to be fairly frank about things from time to time with certain folks. But frankly, if you're willing to change, then that is what you need, and that is what you should be pulling for, is someone to help you. And then the final thing is self-discipline. This is one of the hardest things, especially for leaders, and that's leader standard work. Do you have it in your schedule every week to go out to visit someplace within your clinic or within a department to understand the barriers the staff face, and talk to them about that? Listen carefully. Do you have time in your calendar to do that? My teacher told me years ago, look at your calendar and tell me which one of the things you're going to do next week is actually going to add any value to patients. And when I saw that that number was 0, I realized I got a problem. And so I started to think about things differently and started to think about my own calendar and other things differently. So this guy is Mr. Dubé, Gray Dubé. He's in that hospital on Laretong. They had large outpatient department, large inpatient departments. And we asked him, what was his biggest barrier to becoming an effective leader? And this is what he told us.
Good morning, Mr. Dubé.
Morning, Dr. Fanzu.
Yes, can you tell us what was the biggest barrier for you to overcome to become a lean leader?
Yeah, the biggest barrier was the mind shift from being a solution provider to the frontliners. Instead of them investigating, coming with solutions, and also leading with humility and having self-discipline not to provide solutions to the frontliners. Thank you.
So if we go back to that radar chart, leading with humility and self-discipline were his 2 gaps. So when he filled this out, he rated himself low on going to see and listen and leader standard work. But what he did was he moved from basically not going to any department or clinic during the week to going there 5 hours a week. So he actually went out into the work 5 hours a week as the CEO. That's amazing to me. I mean, when I was CEO, if I got 2 hours in a week, I was lucky. So this is the kind of leadership challenge that we're asking people to make in terms of building excellence in everything I do. This is the CEO of UMass Memorial in Worcester, Massachusetts. His name is Eric Dixon. We asked him the same question.
The greatest barrier I had to overcome to become a lean leader was myself. I have been an emergency physician for well over 20 years, and I like to walk into a room, I like to take charge, and I like to direct people about how to get things done, especially when there's pressure, especially when I feel a sense of urgency. And I bring that clinical background to what I did from a manager perspective, and that is the worst thing you can do as a lean leader. And that what comes out over and over again for me, and I've been able to overcome most of that, although I still have that problem inside me, by talking to the people around me that are on my team and telling them to signal me when I'm in that trauma doctor mode, emergency physician mode. And so there's multiple members of my team that I trust that will tell me, you're thinking like a trauma right now, when we actually have to take a deep breath and step back and hear what everybody else is saying. And I catch myself doing that every week. And that's the good news, is that I catch myself because my team helps me stop doing that. So it's been a great experience.
So thinking like a trauma, very, very, I love that comment. And, if we look at where Eric's gaps were then, right? Reflection and his partner system. So he built a partner system within his own team to say, hey, Eric, put the brakes on here. This is not a clinical emergency. This is a management issue. We need to step back and take a deep breath. So we need care models. And the way I think about care models, now we're on to systems here. Okay, what are those systems? So we've talked about principles, we've talked about behaviors, and now we're going to talk about systems. And one of those systems is building care models. So we need to figure out where our biggest headache is, right, as clinicians, and we need to go fix that. So we need to focus that on a business problem. We need to do this from an inch wide, mile deep perspective. So we're going to change a lot of things, no matter what it is we're changing. Is it the entire primary care experience, which is what we did at Theta Care? Is it one aspect of that? But we're going to go an inch wide and mile deep to completely change the performance of that particular area. And then we're going to create new standard work. And that standard work is going to be the process by which we're able to create reliability. And if we're following the standard, then we can improve that standard. But if we don't have that standard work in place, we can't improve anything. So that's the key here is inch wide, mile deep. Let's build a set of standard work that we're following. We're all following. We all have specific roles and responsibilities. And then when we find a better way, we'll change it and we'll improve it. And True North is nothing more than the core purpose of your organization. So if you've defined your purpose, then this work should actually roll up to help you achieve your purpose. And then finally, if you're in a large organization like many of the ones I work with, you've got to have somebody at the senior level to be supportive. If you're in a small clinic, I think you can get this done a lot faster and a lot easier than if you're in a big 1,500 person clinic that Eric Dixon runs. And here's what we're looking at. So here's an example of waste, right? This OR tech is running all over the place. This is her day trying to find stuff. And because it's not there, it's not where it needs to be. Have you ever had that issue in your primary care office? I had it in my office all the time. I couldn't find anything. So then what we did was we did something called 5S, which basically is to put all the stuff you need right within 2 feet of your work. And you can see the dramatic improvement from that to that just by doing something simple as putting the things that we need to do our work within 2 feet of our work. We can't get away from this. I'm sorry. This is called a value stream map. This is what we did. This was an ambulatory care clinic, actually one of our model cell primary care clinics. We had to map out the future state of the work. The starbursts are where we had big bottlenecks or barriers, and that's where we had to focus was on those particular steps. So each one of these boxes represents a step in the process. And we had to, in some cases, eliminate a number of steps in order to better serve our patients. This is just an example of a GI clinic out in the west coast of the U.S. and Kaiser Permanente, dramatically improving their colonoscopy delivery within 10 days of a call. And again, because they did inch wide, mile deep, complete change of the process, dramatic, 50, 80, 90% improvements. We need a management system. I'm not going to spend any time on this today. If that's something that you're interested in, there's a book called Beyond Heroes. And in that book, written by Kim Barnes, you can build this entire management system on your own. We give you all the tools to do that. But the key is that if you don't have standard work for your management system, you can't support the improvement that the frontline workers are making. So again, I want to say that again. If you don't have standard work for your management system, you can't support the improvement that the frontline workers are making. So it's very important to understand management systems as one of the systems that are critical to improving care. And this is not something that you wake up one day and put in place. It takes work. Again, to build the standard work around a management system that supports the daily improvement of the work. And then finally, I would just show you that this status exchange is the way that the management system actually works. We have information flow from the president of the system, and we have information flow from the frontline nurse. and there's these tiers of management that are going on every day in terms of conversations. Again, it's a relatively complicated process, but it's very, within 4 months, you can have this up and running. And we've seen it in many, many institutions around the world. This is just an idea board. You saw an idea board from Johannesburg. This is an idea board from Canada. And this is the results that they're checking on. This isn't high-tech stuff. It's this, they call these watermelon charts. Green's good, red's bad. Red says we need to improve something. So again, can we 3 feet in 3 seconds understand how we're doing on what we said we want to do? So I'm back to these questions. Can you answer these questions? Do you have the systems in place that we've talked about? And I think that, that's really what this comes down to, is that we as clinicians are so busy and overburdened that we can't step back to actually think about how we could do things better. And by answering these questions, it's a way of understanding how we can potentially do things better. So in recap, principles are the bedrock of any culture of excellence. Culture is determined by the specific behaviors. Systems and standard work reduce human error. And how you build a culture of excellence is by answering the questions in my presentation. So this is just what we do. We do a lot of custom ed. We support the Healthcare Value Network in the United States. We support the CEO network of European leaders in Europe. And we do these different conferences. We teamed up with the Lean Enterprise Institute to do our conference now here in the States. And we're going to team up with the Shingo Institute to do our conference in Europe. There are a lot of resources on createvalue.org that are free. Many papers, many podcasts, a number of experts that have helped us over the years are on that website. So I would suggest you spend a little time there if you're interested in actually building the systems that support good behaviors. And here are the books. The newest book is Every Patient Counts. That's the one from South Africa. You'll recognize the South African flag and some of their religious artifacts. But these are the books. Becoming the Change is really about the behaviors that we've talked about today, and then you can see those other ones. So we have site visits that you can go to. We do that at UMass Memorial. They're a fantastic organization to visit, and we're going to do one at Ohio Health, which is also a great visit. So if you're around and you want to see what good looks like on both the inpatient and outpatient cares, we have opportunities for you to do that. And I'm going to stop there, and I'm going to stop sharing. And I think we're going to take questions if it's all perfectly clear and you don't have any questions, that's great. If you would like to follow up on some of this, I'm happy to do so.
Great.
Well, you.
Oh, sorry. Thank you so much, Dr. Toussaint. We appreciate your presentation today. I didn't see any questions in the chat, but Dr. Nada will be checking that to see if there are any or if she received any by email. I did want to go back to one of the slides about, can you talk a little bit about how do you decide which things you're going to work on? So focusing, prioritizing, and then deselecting the rest. I saw that slide flash a little bit. So I just wanted to just get some thoughts on leader try to figure out, because the tendency is sometimes to take on a whole lot. As you said, it has to be an inch and a mile deep. Thinking about that, it means that we kind of focus on a couple of things or just one or two things. But how do leaders try to figure out what should take priority instead of, because everybody's coming to us with all the problems all at once?
Well, that's a great question. And actually, it's kind of a $64 question for leaders in healthcare, because almost every organization that I visit has hundreds of initiatives, not just 50. I mean, they have hundreds. And it's like, you wonder why all of our clinicians are so overburdened. Because the reality is, if you have hundreds of initiatives, guess who has to do the work? It's the frontline managers, the frontline workers. Those are the people that are getting this work supposedly done. So one of the most critical things, and again, I look at that as a system, okay? We need to build a system that allows us to deselect initiatives. And the system that we build starts with a what we call a strategic filter. So this is a set of yes/no questions that gets us to, this initiative is mission critical, this initiative is important, this initiative should go on hold, this initiative we should just take off the plate. So creating that filter of yes/no questions about really the prioritization of the work is the first step. The second step then is, once you've prioritized by mission critical, important, waitlisted, we're not going to do it at all, then we have to understand what the resource requirement is for all those things. And so then we have to match up, okay, here's our IT resource, here's our HR resource, here's, the resources we have. And then we have to say, okay, let's look at the mission critical initiatives and just see how much resource that's going to take from our core resource group, right? What I have found is that once you get through your mission critical initiatives, you have absolutely no resources to do anything else. But until you do that, until you run that exercise, the rigor of that exercise to say, what's the priority level and what's the resource requirement, then you just keep doing all this stuff. And the reality is, you never do any of it very well. That's the problem. When you have 200 initiatives, you never do any of them well. And I think, when we pursue excellence, we're talking about defining the most important, the mission critical things we must get done, we must accomplish, and making sure we have the resources to get those done. And in many cases, we don't. So then we have to go back to the drawing board and say, well, we either can't do this or we really have to change it so that, we can, that we have the people to do the work.
Great. I appreciate that. I see in the chat that somebody would like to have the books displayed. So I'm wondering if you can share your screen with that slide with the books, if you can. And I also, while you're doing that, if you can, so you had a slide initially which talked about system errors being 95%. Of the problem versus human factors. I think they want that slide, correct. So then that 5%, I would guess, would be human factors. So what's the best way to reduce those?
Well, I mean, there's many ways to do that. I mean, I think the key for that the message about that slide is that fix the system problems first, because that's where you have the greatest opportunity to actually pursue excellence. And sure, you're going to have some people that maybe don't want to be there, that maybe aren't as motivated as others, that aren't, so there will be some of those types of folks, but 95% of the people that are there need a better system. So fix the systems and you will fix almost all of your problems. So I wouldn't focus on the 5%. I focus on the 95%. I'm an 80-20 guy. If we can get 80% of this thing a lot better fixed, wow, that'd be awesome. Because we got so many problems that, it's out of control. So if we build the systems that reinforce the behaviors, we will take care of most of our problems. Then when we've done that, now we can go work on the 5%. But don't go work on the 5% until you fix the 95%. That doesn't make any sense.
Great, thank you. So I know we have just about 7 minutes. I'm going to ask one last question and look to see if there's anybody else who's asking any other questions. But how do you measure whether the leaders are changing behaviors?
So, we think about measurement as, okay, we have a number, a quantitative number. This is how we measure blah, blah, blah. That's not what we're talking about when we talk about understanding leader performance. What we're talking about is a qualitative system, which is why I introduced the idea of going to see. So as a coach, I go observe leaders. And in that observation, I can determine whether they lead with humility. I can determine the types of questions they ask at the clinic or wherever. I can determine whether they're actually listening. I can determine if they have a system for feedback. I can determine just by looking at their calendar if they have any standard work. So that's how we measure it. We say, these are the things we're looking for. These are the behaviors that we're looking for that are observable. So the idea is, what are those observable behaviors that we can actually go to see? And is the leader leading with those behaviors or not? So that's a qualitative, measurement of leadership behavior. But another reason why it's really, really important to go see, to go to the place where the value is created for the patient and see how people are interacting, both within the team, with the patients, and I understand their actions.
Great, thank you. I am going to ask Dr. Martinotter, did you receive any questions by email? We just have about 4.5 minutes left. Or were there any other questions that anyone wanted to put in the chat before we close out the webinar? Dr. Martinotter?
Apologies. We've not received any questions via the email. The email is also there if you want to contact the core group in any way. John, just a question. The term human factors can lead to confusion for some. Certainly it has done for me in the past when I started to get in contact with this science. By human factors and your 5%, did you mean the staff involved? Because the science itself is about systems, working on systems. Did you mean the frontline staff and changing behavior in frontline staff? Is that what you mean?
What I mean is that 95% of the errors are process problems.
Yeah,
not people problems.
Yeah.
The people make the mistakes, but they make the mistakes because the process is perfectly designed for them to make mistakes.
Yeah.
And so when I think about systems, it's about designing a system that basically builds quality into the performance so that you can't make a mistake. And there's lots and lots of examples about that, right? So that's what I'm talking about, is that if we look at problems in healthcare, errors in healthcare, 95% of the time, we could have designed a process to eliminate that error.
Yeah.
And that standard work around that elimination of the error is what many organizations just don't have. They don't have the standard work to actually eliminate errors.
Thank you for the clarification. Rowan, over to you.
Okay. I don't think there are any more questions. And I don't see any in the chat. So I just want to thank everyone for attending today. I want to also thank Dr. Toussaint for sharing his wisdom and all of his experiences. I think there was a lot of food for thought. This webinar will be available, I think, on the WONCA YouTube channel for those who were not able to attend. But I'd like to thank everyone for attending today and for your interest and your participation. And we look forward to hearing again. There will be other webinars coming up. So I want to just thank everyone for here today.